I got to tell you, I love the whole transcript thing.
Yes. Let's see. Are you waiting room? All right. Hello, everybody. So as people are starting to file in from the waiting room, I just wanted to say a few words of welcome. So for those of you who don't know me already, I'm Samantha Bellinger, and I'm the VCHIP program specialist for the PQC, and I work with the majority of you on our AIM rollout across the state. And so this particular webinar is part of our AIM series, which is currently focused on the implementation of the hypertension safety bundle. And today, Dr. Meyer is going to be presenting on debriefs, multidisciplinary reviews, root cause analysis, safety, and adverse events as they relate to our AIM safety bundles. But before turning it over to Dr. Meyer, I do want to touch on a few housekeeping items. So you all should have been muted upon entry. We're just asking everybody to keep themselves muted while listening to cut down on the background noise. And you are welcome to ask questions at any time during the presentation. You can use the chat function, raise your hand, or unmute yourself and ask directly. And this recording, this is being recorded, so it will be available for view later in the week. So it will be emailed out to participants along with the satisfaction survey, and it's going to be on our website in a couple of days. So at this point, I'm going to turn it over to Dr. Meyer.
Sadly, no financial interests. You know, I keep waiting to convince somebody to pay me extra, but usually I just get you get paid your usual extra, which is zero. But this webinar, I just want to remind everybody, is actually not unique to the hypertension bundle. Every single safety bundle includes issues of debriefs, multidisciplinary reviews, and I threw in the root cause analyses so people knew what they were, and it made this more generic towards assessment of adverse events. And there's a lot of stuff in here. And I'll be honest with you, just from even looking around the network, I do feel like there's probably a bit of variability in terms of debriefs. And I think that there's not written actually a lot about debriefs in small hospitals, which debriefs, all of these reviews by definition are very personal. And when you're talking about the same 4 people being involved in most of the events that might happen, it can make reviews difficult. And so I wanted to just acknowledge that up front. These are not easy. They're not easy here. And I can believe that they are even more challenging in low volume settings. And I talk about a little bit, but I just wanted you to know that I acknowledge that. And I have some things at the end to help you. And mostly an offer that I'm always happy to be a sounding board, and sometimes somebody from our department and even from anesthesia will be like a quality consultant for your QA&I committee because it's so difficult to get it done with very few people. So basically, you know, there's a tremendous amount that's written about patient safety in OBGYN. Obstetrics is always really a spotlight, right? But many of if you do any of the hospital reviews or hospital questionnaires, people ask about safety culture. And I wasn't always 100% sure exactly what that meant, but turns out, like everything else, there are definitions. Safety culture does specifically refer to just a commitment to safety that permeates all levels of an organization. And that starts from the people that are checking people at the desk or picking up the phone to make an appointment all the way up. And associated with that is a just culture, which also shows up in many institutional questionnaires and reviews. And what that just culture does is recognizes that competent professionals, people just make mistakes. We are human. And it acknowledges that that might happen, and that some people do develop sort of unhealthy norms, such as shortcuts with our EMR. Those are almost necessary to survive without losing your mind every day, and routine rule violations, and really trying to identify those areas, not to say you can't do it, but to fix it so that you don't have to do that. And a just culture does recognize that human error is inevitable and that what we do every day is super hard. And that the first step in the delivery of safe healthcare is to identify and study the patterns and causes of error within those systems. I actually didn't know this guy before I started, but I did know this quote. So I wanted to, remind everybody, we start pretty much every root cause analysis, we do them all the time, with nobody goes to work to do a bad job. Well, it turns out it's related to this guy. Turns out he's an engineer and he's a statistician. And in fact, he was central in the design of a lot of the Japanese systems that they use in Honda, Toyota for really high reliability output. So, and again, fundamentally, he was more of an engineer kind of person, but he was actually a consultant as they were sort of rebuilding Japan after the war. And he talked about the system of profound knowledge, which sounds kind of like a transcendental meditation statement. That's my daughter's very into it, but appreciating that there is a system, understanding that there is variation in the system and what that variation is, understanding that you're working with people. This is the whole person thing. And understanding that this random theory of knowledge, that there are limits to what knowledge can do in terms of developing systems to work reliably. He's actually credited with the PDSA cycle, but he was, even at the very start, was very clear to say, nope, this guy Short was the one that really started. It wasn't exactly the PDSA cycle, but it basically turned into the PDSA cycle. And so this whole PDSA do, right? Plan, do, study, act. It's probably what every quality meeting you go to starts with something like that. And anyway, this is where it comes. But this is I think, the most important piece. Nobody goes to work to do a bad job. Everybody wants to do a good job. We need to set up the systems that will allow that to happen reliably, because we are human beings. So I wanted to make sure I got all my definitions right. So this is from the Office of Inspector General in terms of the definitions of adverse event, which is an event in which care resulted in an undesirable clinical outcome that's not caused by the underlying disease. And this is not always as simple to parse out as you might imagine. And means that prolonged patient stay caused permanent harm or required life-saving intervention or contributed to death. Patient harm is harm to a patient as a result of medical care, including the failure to provide care needed. And it refers collectively to both adverse events and temporary harm events. And temporary harm is, of course, intuitively that harm that required some medical intervention, but didn't really result in patient stay or require life-sustaining intervention. These are different from sentinel events. A sentinel event is a safety event that results in death, permanent harm, or severe temporary harm. They're debilitating for everybody. I'm going to get to that in a minute. At the end of the talk, I'm going to talk about it's not just the patient that actually suffers from these events. And The Joint Commission, some of you guys are Joint Commission accredited, some of you are not. Follows these Sentinel events, and you can poke around on the Joint Commission all the time. But basically, from an OB standpoint, this is just what the definitions are in terms of things that are not related to the natural course of their illness or underlying condition. And while not every severe maternal morbidity is a sentinel event, because so many of them are inherent in the patient disease, but pretty much you have to look at all of these events and ask the question, is this a sentinel event? Is this related to disease, or is this related to some systems thing? And that is like, if I had to get the crux of the review part, that's actually one of the most important things. But anyway, you can think about severe maternal morbidity, which leads to permanent harm or severe harm. Surgery or other invasive procedure performed at the wrong site, the wrong patient, or that's wrong, the wrong or unintended procedures, regardless of the type of procedure, the magnitude of the outcome. If you discharge an infant to the wrong family, an unintended retention of a foreign object after a procedure, or, and I was surprised to see this, severe neonatal hyperbilirubinemia. So these are actually considered sentinel events and will need to be reviewed and stuff. It doesn't mean that there was any error, but they need to be reviewed to determine what if there was a problem. I have presented to you guys as part of AIM a number of times what severe maternal morbidity is. Remember, those are the ICD-10 codes we're actually pulling from the discharge data for you. These are the ones that are reporting to AIM. You're seeing them now for the first time in your stats report. The most common ones, there are 21 specific indicators. There's obviously more codes to that, but these are all ones, those are codes that relate to these 21 things. The most common one, by far, blood transfusion, pulmonary edema is a favorite. Sepsis, in some areas of the country, this is really high. ARDS, air and thrombotic embolism. We've had a few cases locally of that. Eclampsia, puerperal cerebrovascular diseases and acute renal failure are the common ones. These are the less common ones: cardiac arrest, DIC, anesthesia problems, but they are all the ones that get pulled. And a significant number of people actually have severe complications that start even in the postpartum after they leave the hospital. About 1 in 6 or 1 in 7 occur after discharge. And this is a really important group to try and meet. And this is, you'll see that that is the one thing that's embedded in the hypertension guidelines specifically, is identifying these people. I would say especially postpartum stroke and postpartum DVTs and PEs are probably the most common things that might happen after discharge that we might miss if we don't look for them. So I can't remember, one of the safety things I read, this was kind of statement was there, and I just felt that it was important, right? This is what we do every day is super complicated. And people that don't come up to labor and delivery very often do not really appreciate that. Our doors are locked, and our joke is I have to like give people like instructions on how to get to the unit half the time. If you call a code up there, no one ever knows where it is or what they're doing. So it's complicated. The fact, and what we do every day has aspects that are absolutely not controllable. We all know that. And we have probably more patient effects, right? People that say, no, I don't want this, no, I don't want that we're always modifying what best practices do. So I remind people, and I will tell you, as I'm asking for the whole 7th floor, I'm like, we are a triage unit. We are a birthing center that people that want low intervention births. We are an ICU and a PACU, and we're an operating room, all in one unit with the same group of nurses that have to be facile at all of these things across the breadth of communication. And so it is super complicated. So first, thanks for coming to work every day. And it's just not that different from parenting. Happy Mother's Day. It seems hard because it actually is hard. So remember that reviewing a case does not mean an adverse event occurred. An adverse event does not mean that there was an error. Just because you have a good outcome doesn't mean you should not review that case. And just because you have a good outcome doesn't mean there's no error, right? So in an ideal system, and I think this is especially true for low volume hospitals and honestly every hospital in the state, besides us, the low volume hospital, even we're on that lower end nationally, every single thing you do should probably have some kind of review. And I'm going to go through that and how you can make it faster. It is just as important to review how things go well as it is for things that go less smoothly. Sometimes things go well because everyone is acting outside of what the standard operating procedure that's on paper is. Those are the kind of things you need to know. If things only work because people are breaking the rules, then you need to rethink some things about how things are set up. And along those lines, identify all those common workarounds. We've all got them. We own them. So I came across this paper. I've never really thought about this that way, but apparently the safety people who maybe have a little too much time on their hands separate out safety issues, and they call safety 1 areas as the study of only unwanted outcomes, and safety 2 is the study of all events. And all I wanted to do was just to highlight that this is a thing, studying every single event. If you only study things when they go badly, you will miss stuff. We do a lot of near miss reviews, lots and lots of them. The other thing that you need to think about within your own institution, and everybody on this call should be able to write out very specifically, if there is a problem, where is the home for that problem to be solved? And what is the process by which it is solved? And if you don't have those elements, it is virtually impossible to really make reviews meaningful, because reviews aren't that meaningful unless when you identify something that's actionable, you can figure out a way to actually move it forward. So I'm just going to tell you what we do. So you need a standard mechanism to identify a need for improvement. That's basically case finding. We're still not great at this. But when we have a group, we actually have a multidisciplinary group. It includes at a baseline the L&D nurses, anesthesiology, and our Baird 7 nurses. Those are our postpartum and antepartum nurses that can just review the issues together, see exactly what goes on, and see where in the system needs improvement, and think about how to change, how the system needs to change. You don't have to get into the weeds about actually implementing it. And sometimes you need to get a little better buy-in from everybody to figure that out. But you need to have a relatively tight group to figure out what actually needs to be changed. Then you actually need a group, which may be a different group, and for us it is, that is the implementation group. Again, education review doesn't do anything unless you identify something and actually implement something. And then you need to have an educational process. We also don't do this correctly every single time. So that when you have a process that needs to be changed, how to educate everybody and to make sure that people, sometimes it's just an email, by the way, we have this new form. Sometimes you need a full-on simulation and a drill. Sometimes we'll put it into the nursing education, ongoing education assessments. It just depends on how complicated it is. But you need to have that then follow up from an educational process. I do realize that many people will come back and say, oh, but you have to measure whether or not your change made an impact. Now, if I had all the time in the world and had like an army of people, I might do that. But this is where I know that I personally am like, okay, perfection and being the enemy of the good. If I have to follow up on every change that I feel is needed for safety, well, if they're important for safety, I do follow up. But every single change that helps with move the system along, and I have to get follow-up data and report on it, I would be paralyzed. I wouldn't be able to have time to do anything. I am giving you permission to make relatively small changes and follow up only on those things that are very, very directly impactful. And don't let this, we have one thing you can tell, I have one issue that's been kicking around for a year because somebody wanted to make sure we didn't implement it till we measured it, and we still haven't done it. It's a year later. So those kinds of things, you just have to be super careful about how you weigh those things out. So here are the types of review. You can have a debrief, and I just want you to know that as I looked in the literature, there's no place that really hold them out like this. And so I just want to tell you that some of this stuff I made up. And so I'm always very clear when I'm just making stuff up. But I do know that these are things that we do and that we do them differently. So that's where the genesis of this chart came from. But it's not something that people necessarily put in the literature. But I will tell you, people use all of these terms in a very sloppy way in the literature. But this is more of a grassroots sort of how you might want to think about it for your place. So debrief. Really, everybody, every case ideally should have a debrief. And you should be ideally as proximate to the event as you can. These are not terribly structured. These can be after delivery. Thanks, everybody. Good job. Was there anything that we needed to do differently? It could be done in the room with the patient sometimes. Here is the focus on these debriefs. I cannot stress enough this interpersonal communication. You're the person at the time providing some care. The other people, the nurses or whomever, are also providing the care. This is the time. This is by far your best thing. First of all, because we know most errors are communication errors, doing a quick debrief after every case will make that communication natural, spontaneous, expected. And so when something that's more difficult comes up, it just allows, it's this practicing of talking to each other as a system at the time that reduces that barrier. That alone, I feel like, is by far the most impactful thing you can do. Ideally, they should take place in labor and delivery or in the operating room at the time and possible, usually on the unit if it has to be later. And again, the end product should be that you identify some system issue. You don't have to know how to fix it. You don't even have to know that it's a systems issue. You just put the problem down in the simplest way. And sorry, nurse managers, slide it up under the nurse manager door so that people can be like, okay, I know I have a home for these problems, and this piece of paper is going to go into that. Good, it's going to start because it's going to go into this home for problems to get worked through. This simplest, quickest, and I would argue by far the most impactful, because this is going to help your every single day communication on your unit. And no, ours is not that great either. Ours could use improvement. How about that? Multidisciplinary reviews, these are going to be a bit more structured. They're going to ideally be proximate to the event, but they're going to be in some kind of a QA&I forum. Some of your QA&I things might be at the hospital level, some might be at the department level. This is where only having a few people in a department can make it difficult. And these are almost, and the most important thing is you invite everybody that was involved, right? Anesthesia, OB, peds, both, some internal medicine person you brought up, if you brought the ED up to help you, whoever you brought up to help you in that case, they should be at this debrief. And it's often we do these, and within some type of QI meeting, we actually don't do these in our Q&A. We don't always, we do sometimes in our Q&A meetings. Our anesthesiology colleagues They're awesome, and they actually have a little M&M spot on Thursday mornings. We'll plan and that we're going to do a joint conference in their M&Ms all the time. Sometimes they're also invited to us, but and so it just depends on the way your reviews are structured. These are more structured, and this is systematically, and these oftentimes are focused on how our different teams communicate and coordinate care. So everybody needs to be invited, and the end product, again, should be, living in that home, knowing where you're going to solve your multidisciplinary problems. A root cause analysis is formal, facilitated, still by definition, if you're JCAHO accredited, have to occur within some period of time. There are people that are involved that are facilitators and know how to run these things. And this is another thing in a small hospital. If you're not sure how to run a root cause, then again, we're always happy to help talk people through it. Lori Notowitz is our safety person. She's awesome. There are tons of things out there to help you run them. I am certain that we can help facilitate them. Usually they're within 2 weeks if there's a sentinel event. They are very structured. I have a few more slides on these. They're focused on system improvement and oftentimes across the hospital and every area that touches the system. These are formal QA&Is. And after a root cause, there is actually a structured plan with follow-up that happens over the next year. So there's a plan that's made. There's 3, 6, and 12-month follow-up. So these are very, very structured. So debriefing. Debriefing after every event is great practice. Again, practice, practice. Communication is our strongest link to the culture of safety, and it reduces the stigma of having a debrief. I don't want people to hold back. Oh, if I debrief, that means I'm going to be in trouble. No, it just means you're going to all talk and say what a great job you did. Yep. And again, I think that this is by far the best way to improve communication. And again, not only are debriefs at the time important, but also you can practice these in your in situ drills and your simulations, and during these two things, you can have debriefs at those events too. But I think every single day, if you did it after every delivery, you would just start working through the little things that might help the unit run more smoothly. There's actually an awesome article if anybody's interested on the history of debriefing. And I kind of like this guy too. So this guy was a historian, and he was charged with documenting the World War II events as they unfolded. So he was kind of real time at the front, and he was initially just used all the paperwork that was related to some battle or event to kind of reconstruct what happens. And then he was like, I can't make heads or tails out of these. And so he just started to go interview the guys that were involved in these things immediately. And so he was the one in the military that really transformed what had been you made this error, you made that error, or a very punitive, blame-based approach into something that really turned into objective performance indicators with a non-punitive atmosphere that really fostered people thinking about and learning from what happened. And the reality is we really are on the battle lines, right? The FAR objective training system is to prepare the combat officer mentally so he can cope with the unusual and unexpected as if it were altogether normal and give him poise in a situation where all else is disequilibrium. I think you could really describe every single labor and delivery unit as that. And this is the other thing that I really like. I appreciated from him that in any man's dark hour, a pat on the back and an earnest hand clap may work a small miracle. And we definitely do not do this for each other enough. I'm going to talk about that a little bit at the end in terms of supporting each other. But just to know that no matter what happened, even if it is some blatant error that somebody did and had a bad outcome. They did not do that on purpose. And we need to support those people to help them through it. And there's more on that at the end. So debriefing is clearly the linchpin of learning. Debriefing is a post-experience analytic process. It's a discussion of the experience, understanding and integrating the lessons, and to explore what happened, why it happened, and how it might be better next time. So first, decide which events you're going to be debriefed at, or all of them if you can. You do need to get buy-in from everybody. You can literally commit 5 minutes in the OR or the delivery room. As everybody knows, now you have all these W8, these WHO guidelines, right, for the OR, right, at the end of the case. You know, the surgeons say if everything was all fine, now they're lucky all their patients are asleep, all of ours are awake. It's a little easier if they're all asleep. But decide who's going to lead it. Ideally, it should be the OB provider, but it could be anybody. Start with what went well, ask about challenges, and ask about workarounds. Did you have to work around any system to get something done that you needed? And make this just a habit and check in. That is by far the easiest thing to do. If you have a really difficult situation, some days that's not the best time to do it immediately after. People are a little annoyed with each other. They just kind of want to argue. They need to vent. Some people need a little space. All, again, totally okay. Use your reasonable judgment. You want it to be productive. If people don't seem to be, they're in a frame of mind right then to be very productive, just hold off, even if it's for a few days. The most important thing is to bring it back together, and ideally within a few days, ideally not more than that. Because if you don't do that, and again, you guys are small hospitals, it makes things difficult, way more difficult as you move forward. So in the drill book, in the resource books we gave you on page 83, this is our hemorrhage debrief, which you can use. And the next one is a generic debrief. Sometimes people don't know how to start conversations. So just grab these, keep them in the room, because that means that nobody has to like do the mental work to figure out what to ask. Just go through it all each time. And so every time you have a hemorrhage, just go through it as soon as you can so that you don't have to sort of make up or feel like you have to lead the debrief. And on page 84, there's a more generic one. You can just decide to use this all the time. Leave this one in the room. It'll cover hemorrhage. And just this way, you don't need to feel like you have to make up what you're going to do. The script is right here. You can just go down, slip this, sorry, nurse manager, under their door, and that way you can get it followed up on. So I would say if you're not used to debriefing, use the generic form. Encourage the use, even if it's not fully done. Still, just get something on. Ask the nurses, no offense to you guys, you're the only ones that are reliable enough to fill it out and put under the manager's office. But there's no question that this is the backbone of system improvement. This alone, end of story. It will absolutely help your communication over time. Multidisciplinary reviews. None of us works without our anesthesiology colleagues or our pediatric colleagues, or for us, the blood bank. So it is really important to bring other people in. No system improvement is going to be effective without it. Not everyone has to be at every meeting. And at a minimum, for us, for example, we have a nurse leader. We have our educators, our RN educators. They are like key, actually. We have an OB leader and anesthesiology leader. And we actually have, and you should ask for this, ask for a QA&I person. All of you guys have an office. Somebody's getting paid to do QA&I to support you in these reviews, getting people all together, taking the minutes and things like, and running through the systems, because you guys are too busy to do those things. Because again, if you don't do it, it basically, you're just not going to be able to get it done. So you should have help from your QA, because if you don't have an action plan for something, then you know what, you're not going to do anything differently. Root cause analyses, again, I just have a couple of slides on here. I'm just showing you the general framework. It's not any different than any review. You identify the event, you select your team, you describe what happened, figure out the contributing factor and the root causes. And those two things are not necessarily different. Again, these are very structured, they're facilitated, they're leadership driven, and they start with the problem, not with the solution. I love this because it is a good example. It's not something we're likely to do, but it gives you an idea of something that needs a root cause. So this is a patient that ended in an event. There was somebody getting up on a Hoyer lift, and the lift falls and drops on the patient. So if you're going to do a root cause, you have your timeline. Somebody got out of bed. They talk about that they got them up from the wheelchair to the Hoyer. They swung the Hoyer over, and then the lift collapsed. And then you look at the contributing factors, and you totally need a facilitator to do this, because this is not always a natural process. You talk about somebody was in a hurry. You talk about there was only one lift and it was being used in a different location. So there was like just chaos trying to get the lift there. The fact that maybe there's no signage so that you knew what a weight limit was. And that maybe the lift they were using was not rated for the weight of that patient. And that maybe they moved the lift, maybe they didn't operate the lift correctly. And that they weren't trained on what to do if it started to malfunction. And that then there are things, obviously, sometimes you're not under your control. This patient all of a sudden moved. And that and that the lift wasn't really strong enough. So it takes a lot of work to drill down onto those things. And then it gets even worse. You go down into what they call the 5 why questions. It's like having a 3-year-old. Why didn't the CRNAs not have the equipment they needed? Well, because they can't find it. Why can't they find it? Well, they don't have enough of them. Why don't they have enough of them? Because they don't really know, because they don't know how many they needed. Why did they not know? Well, we better figure out how many we need them. Do we have enough of them? And do we need to move them around? That is what the root cause analysis is for. Nobody naturally gets into this. This is why facilitation super, super helpful. And sometimes they'll be sitting there and say, why? And I just want to whack my head into the door because it's like, I'm tired of hearing it. But they are very, very helpful at getting down to the most minuscule. It's not even minuscule, right? We ended up here at strategic planning, but it's the very, very root of what the problem is. So after you identify what your root causes are, and this could be from a debrief, I use that in the generic term, you have to think about what safeguards are going to prevent it from happening again, what contributing factors might trigger. How do we change things so that this doesn't ever happen again? If an event like this happened again, how can you stop the accident trajectory? And if somebody was harmed, how can you minimize the effect of a failure of the whole system? So they talk about 3 different levels of action. So these are by far the strongest actions you can take. You change the surroundings, you test the usability, you engineer controls, you simplify processes, you standardize some equipments, and you have tangible involvement on leadership. Those are real, tangible things. Those are these 2 things, right? There are some intermediate actions sometimes that you take. That's changing staffing, you enhance some software, you get rid of some distractions, you put in some cognitive aids like like the wait reminder. You do read back to ensure close loop communications and better documentation communication. I just want to point out these weaker actions because they by far are the most common. Those are things, oh, you need to double check this, that you have to put a warning somewhere. There's a new policy developed, there's some training and some additional analysis. So as you think about changes, think about how strong they are and make sure that they match whatever the severity of the outcome is, so that you don't have mismatches. And I was looking for things to basically talk about root causes. I found this, which I thought was kind of funny. Swatting the mosquitoes versus draining the swamp. And the point is that this guy, the guy that developed the whole Swiss cheese model, right, of errors where you have to have a whole bunch of them, said that the goal of error investigations was draining the swamp, not swatting the mosquitoes. And the point is these weaker actions are just like swatting the mosquitoes. You can help some things and improve some things, but you're not going to get down to the root. You have to look for these harder, more impactful things to do. And they basically said that a lot of RCAs end up with these, where you really need to think more carefully and being innovative for these. So what about small hospitals? You don't have very many providers. You don't really even have that many nurses. Don't have that many anesthesiologists. It can hard. Some of these conversations are super hard, which is why it's helpful that they're facilitated. So think about planning your multidisciplinary reviews and feel free to get reviews from other hospitals. We do that all the time for people. And we've worked with you guys for a long time. We have a pretty good idea what your limitations are. We know what your level of care is. It's not that hard for other people to get status to be able to review things for your QI committee, so it all stays under a QI umbrella. That would be not discoverable. Everything should always be done under a QI umbrella, and you can get multidisciplinary help, especially if you don't have it there, or if you only have 2 anesthesiologists and they need the input to hear from other anesthesiologists how they might be able to have thought about things differently. All of those things help a lot. So don't be afraid to phone a friend. So the last piece I want to talk about is this second victim thing, which honestly, anybody that knows me, I will tell you that the whole concept that you talk to them, that the term second victim just makes me kind of cringe a little bit. I'm not like a victim kind of person, but I think that the idea of them is correct. And that basically is just the acknowledgement that the care providers that are involved in an adverse event suffer. And we need to know how to support them, how to help them work through it, because it doesn't do us any good. If somebody has a poor OB outcome and then they're like, I'm just not doing OB anymore. I don't have to tell you guys the crisis that exists in OB providers, especially in small hospitals. So we have to be really thoughtful about how we talk about this. And this was actually brought up quite a long time ago, considering the fact that nobody talks about it till now. This was from 2000. And this paper started talking about when he was a house officer, he didn't recognize somebody who was having a pericardial tamponade. And he felt like he got, basically trashed by his peers. We all can see how this can happen. I trained under this particular system, but there's not a lot of sympathy. There's not a lot of support. And these are the people that say, I'm not going to do this anymore. So what do we do when a colleague makes a mistake? How would we like others to react when we have a problem? And how can we make it feel safe to talk about mistakes? And I would even put bad outcomes, because let's just face it, not every bad outcome is a mistake. So it is important to encourage a very clear description. You don't have to minimize that it might be a mistake, but sometimes disclosing your own experience and mistakes. I tell people this all the time. I have a long list of things that I screwed up, but so that they don't feel so isolated, like nobody else makes a mistake, and to acknowledge the emotional impact and coping. And we're not alone in this. AIM obviously requires multidisciplinary reviews and trauma-informed support for patients and for staff. And I think I told you guys when we did the postpartum hemorrhage bundle that I felt like, in general, a lot of places have things in place for patients, but not anything particularly structured for staff. I will tell you that we have a fellow who came from the Mayo Clinic. There's a trauma surgeon there who is particularly interested in staff support, and you can figure why that would be. Trauma surgeons, I'm sure, have a lot of difficult situations where things may or may not go exactly the way they want them to go. And they have put this all the way through the Mayo Clinic. And honestly, they have people supports. They have people in the lab supporting the trauma surgeons, right? So they have a whole training process. It doesn't have to be within your discipline. It's throughout the hospital. So I have a fellow very interested in this. This is working out and developing a model similar to the one that's at Mayo is actually her thesis project. So it'll take a couple of years for us to do. I actually suggested that in her surveys, at least her initial survey, that she put it all out to the community hospitals, to all of you guys. So I don't know if she took me up on that. So, but I do believe it's something that we need to think about, to understand as a state, and to help everybody implement, because I do think that there are a lot of reasons that OB care in rural areas is more difficult to access, and I believe that this is one of them. So in conclusion, whatever you can do for communication, do that. And know how within your hospital you implement change. Debriefing after every event is great practice. It's going to reduce the stigma about debriefing, and it will improve the communication, which is by far the strongest link to a culture of safety. And even ACOG in that patient safety guidelines says that communication is by far, it is involved in 2/3 of the cases that are root cause. So practice, practice, practice. So here are action plans that you can do. Develop a mechanism for you to debrief. Make sure you know how you're going to do multidisciplinary reviews. Talk to your QA leaders and get some help in setting these things up. And again, talk about this second victim issue, what it feels like in your institution. I promise I'll get more back to you as soon as, as Anissa gets her thesis done. But again, by far, you look at the 5 most commonly identified contributing factors: education, which is what we will look at, and communication. Not following your procedures, of course. But way down here, it's really not until you have performance issues. By far, the money is really in here. So with that, I'm happy to take any questions that you guys have. I'm going to leave the slides up in case you want me to go through any. Anybody have anything you want to talk about? You can always email me, as you know, you can email Sam. Yeah, just speak up, because, we can only variously see you.
I have a comment, Dr. Mayer. This is Erin Witchland from Brattleboro Memorial.
Oh, great.
Hi. So within the last year, we took your framework of the debrief form, the generic one, and made some adjustments to it, tweaked it a little. Our quality department had me add a little bit more extra language to it to cover protection. And we rolled that out, focusing on those more high-risk events to start with. And The staff have really taken to it, which is great. I know I'm not getting one for every event, but I try to stay on top of it. And oftentimes there's really quick things that we can address that come out of those debriefs, which is wonderful. And just recently, we finally put together our perinatal quality committee, which we're going to begin the structure of that by bringing the debrief forms and have those be the first things that we work through. I was able to create a safe homepage on our SharePoint site where I can upload those forms so people can review them ahead of time. We're still kind of working out how we're going to process through the review of them. And we're starting out quarterly. I'm suspecting we're going to need to be more frequent than that in order to really keep the action plan moving forward. But that all leads me to saying, I'm really interested in the work that you're thinking about with that second victim. Right now, we do have a great employee assistance program, but basically here is that resource if you wanted, our 3 free counseling sessions. And we don't have a really routine way that we handle it. And, I would love for us, not just for our department, even just as a whole hospital, to really put something better in place. They did put something in place in the ED for patient violence. And so those nurses have like this automatic process that happens for them. So I'll be looking forward to that information. And I just wanted to share that we did roll out that debrief form. The other thing, and I sent it to Sam by email, we enroll in the Perifax program for the University of Rochester. And in February, they had a debrief education. So I'm probably not supposed to send it to, I don't know, they allow you to download the whole PDF with the test, but I assigned that out to every staff member with the expectation that they complete it. It gives a little more of the why we're doing the debrief, and it's not just Erin says so. So I've sent that out to everybody, almost everybody's done it. But that's kind of where we're at with it. It really just came to fruition within the last year. So we're excited.
Oh, that sounds awesome. And I would love to see what protocol your ED nurses have. Since, as you know, I'm always happy to steal from people. We're stealing a lot from Mayo. But I would love to see what they did. And it sounds like you guys are doing awesome. But I especially appreciate the fact that the more you do it, the more you feel like you can do it. It does make it easier.
Mm-hmm. Yeah, I would say that it's really improving that interdisciplinary communication. The next thing we've identified is I need to modify our debrief form to have a line that asks them who is part of this incident but not part of the debrief, so that our group can kind of swing back with those folks in a timely manner and get their feedback also, so we don't just lose that extra information. Because
that's great. And anybody that, and I'm going to presume that if anybody wants them, they can either email you directly or go through Sam. However we can help that area is fine.
And I'm just going to toot Erina's horn here. My name is Leah Nessman. I work under her. She has really been instrumental in following up on these. If there is it takes a lot of work, as everybody I think knows. And she's been instrumental in following up when there is an adverse or any kind of unexpected outcome, tracking down the folks involved and making sure that the debrief does get done, even if it is a few days after, and that all that relevant information gets gathered. So it doesn't just happen. There does need to be a champion and a leader, but it's been really wonderful for our unit.
Thank you, Leah, but I will add the one place that I need to do some improvement is more routinely getting back to the staff what I've done with the information that they've submitted. Sometimes it comes out in bits and spurts, or they'll just see the change or whatever, but finding a way to really routinely get that back to them. And it might come out of that quality committee that we're able to kind of put some of those things out there, but I have to figure out that piece.
Oh, we 100% have the same problem. I agree with you. It's that feedback loop that everybody's like, I put all this stuff in, I complain and nothing ever changes. This is it is 100% a very difficult thing. And they're so lucky to have you. And I would absolutely push on your QA&I infrastructure if you need some help, because they've really been very forthcoming here. It's relatively recent. We now have a quality person assigned to us. And they can also help you get data out of the system if you need it, things like that. So definitely feel free to push on that. All righty, 3 whole minutes back. Thanks, everybody. Feel free to call me if you need anything.
Thank you, everybody.